Good afternoon. We're going to start on time on respect of the people who's already here. So thank you for coming. I want to thank IFSO for the opportunity to discuss what is happening in bariatric and metabolic endoscopy that is becoming a new management paradigm. So we're going to start. I want to introduce my co-chair. We call him Ravi because his name is very long. So Ravi is based in Singapore. He did all his training with Contra and Lopez Nava, that who couldn't make it for some personal and business reason. So Ravi, welcome, and thank you for your help. So our first speaker couldn't make it, so we're going to start with Christine. Christine is very, very, very well known in the world of endoscopy. She just changed jobs in Germany, but she's still in the country. She's an expert in almost any endoscopy procedure. And she's going to discuss the continuum, oh, I lost it to Christine. Continuum, endoscopy, and medication. Does it make sense?
Yes.
Yes. Thank you, Christine.
So with that, I could end indeed the talk. These are my disclosures. And indeed, this is a very, very, very hot topic. Why is it? If you look at that, you can see that there are really significant, famous testimonials on the medication. And the presence of the medication in the media is unbelievable. It must have costed so much money to make them so famous. And if you look in the middle, this is from the Brazilian walk. This is a model. I would say she has a BMI of 18. I don't know why someone with a BMI of 18 must know Ozempic, but obviously she loves Ozempic. So it's really a hot topic, and they commercialize that extremely, and it's very, very, very well known around the world from a lot of people, and even Oprah Winfrey had a comment on that. So what do we know? I tried to keep it short because it was 10 minutes, but I'll tell you a little bit more than per slide. But anyways, what do we know about combination therapy? And I think really combination therapy, if it is applied with sense, is really, really the future. But as you see here, we even have limited evidence on combinations combination medication with bariatric surgery, although you can see that there are already meta-analyses, and there was even a randomized controlled trial called the Bariatric trial. So there is some evidence, but it is still very, very limited. And if we, after that, have a look on the combination of endoscopy with medication, you can see this is even more limited than in the case of bariatric surgery itself. Who was really working a lot on that is my friend Sai Bichemont from Boston, who combined medication after transoral outlet reduction with pharmacotherapy and had very good success with that. But even after sleeve gastrectomy, it absolutely makes sense. And you see the last in the row is a publication on endoscopic sleeve gastroplasty plus liraglutide versus endoscopic sleeve gastroplasty without that. Why is it liraglutide? Because semaglutide is not as long available as we already have publications on that. But anyways, this will come, and I think this will rise a lot. So let's have a closer look to this last publication I wanted to present you, the combination of sleeve gastroplasty plus liraglutide. And you can see the results of this study show that the combination of endoscopy plus medication nearly achieves 25% of total body weight loss. This is very, very close to that what surgery alone would achieve. So keep this in mind. This is really stronger than medication alone and stronger than endoscopy alone. It really fits very well together. So there was an IFSO consensus conference on this topic, and our friend Silvana Peretta was the one who was defending endoscopy in combination with medication in this group. But you see, we only could have approved 2 sentences. The most important is the one I show you here, saying although further evidence is needed to determine the value, it is a good thing. And indeed, it is. So how do they fit together? And what I think is, what you really have to know is how the mode of action of each of these procedures or medications is, that you know whether you can combine that very well or not. So when you look at sleeve gastroplasty, you know this is a procedure that is emptying slowly, very much slower than a sleeve gastrectomy, because it has a pouch-like reservoir. We all know that. It's completely organ-preserving. These are all the advantages of this endoscopic procedure. It's non-reflexive because it spares the angle of His, but the mode of action, and this is what I really want you to remind, is the distension of the gastric wall. The distension of the gastric wall is a mechanical thing that translates into weight loss because it is sent, the information is sent to brain via the vagal nerve. And if you look how the vagal nerve is embracing the stomach, you can understand how this information goes to the brain. This is very, very important, that this is a mechanical intervention that translate into weight loss via the vagal nerve. This is also the reason why you will not achieve the same weight loss with an ESG like with sleeve gastrectomy, because of course the gastric wall is not as rigid after folding in the gastric wall instead of, like with the surgery, instead of resecting the gastric wall with a stapler. But the mode of action, again, is really the mechanical distension of the gastric wall that provides fullness and satiety for the patient. So let's have a look how medication is working. And I remember, I think it was 10 or 12 years ago, when a company showed up in our department to want to know how the mode of action of Roux-en-Y gastric bypass is, because as you see from this, from this publication here, which is done by a Brazil group and is fantastic, they wanted to know how incretins work with the surgery, and this company is the one that brought the new medication called Mounjaro on the market. But you see there is really an increase in GLP-1 with the Roux-en-Y gastric bypass. What they do not see very clearly is that it only comes after 15 minutes. This means this GLP-1 release is only after nutrition reaches the common channel. But there was a wondrous transformation in these medications from anti-diabetic medication, and I can tell you the first studies I did for super obese, or how do we say today, Nathan, class 5 obesity, to prepare them or to bridge them to surgery, I took liraglutide completely off-label. I knew this induces weight loss, but it was not approved as a weight loss medication. But you can see that the same pen that contains the anti-diabetic medication contains absolutely the same medication, but is 5 or 10 times more expensive than the medication, the anti-diabetic medication, and has another name. So there was really a wondrous transformation from an anti-diabetic medication to an anti-obesity medication from Victoza to Saxenda. The same is true for Ozempic. I put Saxenda in there. It's called Wegovy, of course. It's exactly the same wondrous transformation, and you have to know that the pens really contain exactly the same, but the name is different, and the patients they are applied for are also different. And this is the new one, Mounjaro, obviously acting even stronger than only GLP-1 analogs, because they combine additionally GIP in this medication. So you have the whole range of incretins. Incretins means gastrointestinal hormones that work on carbohydrate digestion. You have the whole range of incretins, the starting one, which is SHIP from the duodenum, and the GLP-1, which is secreted in the terminal ileum. Interestingly, I found this publication, and I really want you to keep an eye on that, because I think it's a significant information, a significant piece of information you can have about the mode of action of these medications. If you see on the left side, which is a little bit greenish, you can see that this working group showed that there obviously are a lot of GLP-1 receptors in the brain, which indeed I do not understand, because this is an enterohormone. I don't know what it does in the brain. But anyways, it's an enterohormone that is there to stimulate the pancreas. I don't know what it does in the brain, but obviously, as you can see, the green ones, there are a lot of those receptors. But if you give the patient GLP-1 medication, you can see in the first phase, the hypothalamus and the amygdala is not very much enlightened, but it is after there is a steady state of semaglutide. Do you see the rest of the GLP-1 receptors? I don't. So maybe this is just insulin acting on the brain, and as we all know, insulin is the strongest hormone providing satiety. So, but let's see. One thing more. What also is very clearly to see is that the nucleus of the vagus is demarked here, because as you all know, those medications really didn't delay gastric emptying very, very much. So you have the nucleus of the vagus in the stem brain, and you have the hypothalamus and the amygdala in the rest of the brain. So my take-home message for you, why this fits extremely good, you can see on this slide. There are synergies, both of the intervention and the medication has to share together. The one synergy both have is that they slower gastric emptying. This is a very, very important point. Both slower gastric emptying. But while ESG is really not refluxive, with the medication you can have some reflux, and this is also what you have to keep in mind if you induce this. And they complement each other very, very well, because the medication is acting primarily as a hormone, whereas bariatric endoscopy and in special ESG is a primarily mechanical procedure that translates in a central effect, inducing satiety. So they really make a complete picture together, and this is why the combination therapy seems to be very, very, very promising for the future, but we still do really need more evidence, and that's it.
Thank you very much, Christine. If somebody has a question from the audience, I have the first one, the easy one. So my biggest, it's not a concern, but my most difficult decision will be, because I totally believe we need to combine this either before, during, after. So 2 questions. If you're doing an endoscopic procedure, when should we start the medications? Before, during, after, and in after, when? And the same question for surgery. Is a difference, or should we make a difference between surgery and endoscopic intervention related to medications?
Yes, yes. I was trying to define this as neoadjuvant and adjuvant treatment because I think this is very similar to cancer treatment, you know, like escalating treatment. This is what I tried to define with this neoadjuvant medical therapy that was a bridge to surgery, really to surgery in patients that were in urgent need of surgery. They were emergency patients. And this is the indication for neoadjuvant therapy nowadays is not as strict as it was in those 10 years ago because there was no medication that was approved as anti-obesity medication. And of course, we can give prior to surgery medication, and a lot of countries I know that who have long waiting lists do that. But this is without any strategy. We need to define that, you know, we need to define that. And my hope was with this neoadjuvant therapy that obesity is really classified accordingly to cancer in stages. And if we could achieve this, we really could define exactly when to give medication and when not. Because nowadays everybody is doing it. Nobody's publishing on it, but everybody's doing it. And like, you know, it's an emotional decision. But if we could really stratify it and make obesity accordingly, classify obesity accordingly to cancer, we really could define exactly when to give it. After an intervention, and I don't discriminate there between surgery and endoscopy, after intervention, I'll give medication in that moment when patient starts regaining. I don't wait for 10 kilos, 20 kilos, or whatever, because for me, regaining is, again, anabolism, and this is a recidivism of the underlying disease.
Yes, I think plateau will be probably the reason. Suhendra, and then Ravi.
What is the maximum amount of time that you suggest to prescribe the medication along with the endoscopic procedures? And are you worried about any of the rare few side effects that are coming out all the time with this medication? So do you have some sort of a surveillance that you do, and what do you suggest?
I'm always worried, yeah. No, but to be honest, yes, I'm completely worried. I'm completely worried because, as I said before, I believe that the mode of action is much more the insulin than the GLP-1 in the brain. And you know, insulin is a growth factor. And this is, in the long run, this might be a problem. Absolutely. So I'm really worried. And of course, I survey those patients absolutely clearly. They have to come every 3 months to me, always.
So what's the maximum amount that you suggest then?
The problem is the following. The patients have to pay themselves for the medication. Okay. And this sometimes limit to give them the medication in a timely manner.
Actually, there's no data on that also. Yeah, nice talk, Kristen. So one question is, if we do ESG and the patient is adherent to the diet and lifestyle, not a binge eater, still do you think there is a role of the drug? Strict calorie intake?
Is a very good question. I'm completely against strict calorie intake. And because, you know, for me, it's like that. Catabolism is not a natural state. And body will always try to regain because it's a little bit like Scrooge, you know. It's with this set point. I don't know whether it has to be modified, this theory, but I think this is very much the truth. The body will always try to regain, always. And whether people are binge eating or not is a question of hedonic system, a question of regulation, calorie intake, basically calorie intake. And you know, people that binge, for example, in the night, they have so much stress. If they don't go to the fridge, they cannot sleep. So this is a disease by itself. But as far as I know from the publications, the analogs are acting even on the hedonic system.
Thank you.
So there would be a role in my...
Last one. So nowadays there are a lot of pharmacotherapeutic options. Do you have any preference, like be it oral drugs or daily injectables or weekly ones, to increase compliance? Do you specifically choose one over the other?
This is so good question, but it is a question that I really have to answer very basically, because this is always the question of the costs. You know, what is cheaper? And in Germany at the moment, Mounjaro is much cheaper than Ozempic and Saxenda. So I prescribe Mounjaro because I want my patients to have the chance to get this, you know?
Thank you, Christine. Next presentation, gastric remodeling techniques, current and future platform. Rabia Sokumar from Singapore.
Thank you, Chairman and organizer, for this wonderful opportunity. Today we will be sharing on gastric remodeling techniques, current and future platforms. These are my disclosure. As it has been highlighted earlier, when it comes to weight and weight management, what we are trying to do is basically alter the normal physiology, which is dealing with hunger, controlling your satiety, which is the time interval between your meals, and also induce satiation early. And there are many different pathways that are involved, many different signals that are involved in controlling different aspects. So where endoscopic treatment comes is basically to restrict gastric volume so that we induce satiation early, and we also want to modify, interfere with your gastric motility so that we keep you satiated for a long period of time so that your inter-meal intervals are longer. And we also, by modifying these factors, we want to induce significant and sustained weight loss over time, which eventually leads to improvement in medical comorbidities. Much of what we do in endoscopy is things that we learn from surgery, and the difference between endoscopic treatment and surgical treatment is basically we are trying to achieve restriction, but at the same time we preserve anatomy. Where in surgery you're going to have resections, change in vasculature, neurological innovation to the stomach, and so on. So endoscopy is any technique that we talk in endoscopy is going to be organ preserving with an idea of generating the same restrictive effect with the bariatric surgery offers. So with that in mind, currently we have different platforms that are available. Some are widely available, some are in early phase of development, and some are restricted to certain regions. Among them, ESG, which many of you are familiar with, by Boston Scientific, is what is widely available. Then comes primary obesity surgery, followed by Endomina and Endosip. So endoscopic sleeve gastroplasty, now we have different, it started as Gen 2, which requires a double-channel endoscopic system, followed by now SX and the next generation systems, which can be mounted on most single-channel endoscopes from different platforms. So this is a typical endoscopic sleeve procedure. As you can see, we are using the newer Fuji systems, where your visibility is much better and you do a continuous suture. In terms of suture pattern, we typically follow an U-shaped suture pattern, starting from the distal aspect of the stomach, and we go in proximally, and we try to avoid involving our fundus. So the whole intention is you collapse your greater curve as much as possible, and then you bring the tissue together using a cinch mechanism. We just cut it, and then you can now see that the distal aspect of the stomach is restricted. The whole idea is you do this continuous suturing involving the entire greater curve to restrict the stomach significantly, so thereby you you decrease the meal volume, induce satiation. So we spare the fundus. We very well know from surgical literature that at least 20% of the patients who go for laparoscopic sleeve experience reflux symptoms. With endoscopy, by preserving the fundus, which acts as a reservoir, you decrease the risk of reflux in this group. The landmark trial, spearheaded by Baham, as we all know, was published a couple of years ago in Lancet, shows that despite having this trial run during COVID, you can see significant weight loss, and this weight loss was maintained until 2 years. And those patients who crossed over from diet and lifestyle intervention continue to achieve significant weight loss at 1 year time point, and the complication rates are very, very low. And the weight loss achieved indeed resulted in significant improvement in comorbidities in close to 80% of patients. So when we compared outcomes of ESG at 2 years across somewhat identical surgical procedures, which is lap sleeve and greater curve plication, you can see that with endoscopic procedures, your procedure time is extremely shorter. Within 35 to 40 minutes, you're done with the procedure. The weight loss is around 18.5%. From the look ahead trial, we know that with 7 to 10% weight loss, you're going to see improvement in obesity-related comorbidities, and with endoscopic sleeve, you achieve almost 18.5%, which resulted in improvement in comorbidities at a very low complication rate. The length of stay is also shorter. These procedures can be either done as a day procedure, or where in countries where reimbursement matters, you can keep these patients for a day just for pain control. But in essence, these patients don't really need to be hospitalized for a long duration. So in our own cohort, when we looked at how these weight loss impacted on the comorbidities, you can see that a significant improvement was seen in fatty liver disease, diabetes, and hypertension, and LFTs, as you can see, completely normalized. HbA1c improved by 1.5%, and your blood pressure drops by 10. There is always a question about durability and how sustainable is this weight loss. There are data emerging at different time points. The 3 years weight loss from the Saudi group shows that the weight loss is maintained at around 13 to 15%, and with the combination of drugs plus ESG, you can maintain it until 5 years. So now you can know that there are more options. The treatment of obesity is going to be a continuum. It's not like one procedure you do, the patient loses weight forever. At different time points, you have to introduce all the tools that you have in your armamentarium to help these patients continue to maintain their weight loss for a longer period of time. In terms of mechanisms, how this works, as highlighted before, all these sutures are transmural sutures, and these sutures have shown to restrict the stomach and also decrease the motility. Thereby, when we do gastric emptying studies, you can see ESG at different time points delays gastric emptying, and this effect is sustained as long as 1 year after the procedure. In addition, when we looked at how these procedures impacted on your hormones, ghrelin, we don't see much change, unlike surgery where the fundus is removed. But what we noticed was, we know that when patient goes in for lifestyle interventions with a calorie-restricted diet, the ghrelin always shoots up. And this really makes the patient more hungry, resulting in recidivism. But in ESG, we don't see that spike in ESG, but rather it's plateaued, it's maintained, so they're not that hungry. And secondly, we also see significant improvement in insulin secretion. The change in insulin secretion mirrors similar to what happens after surgery, and there is improvement in insulin resistance, which has been proven in multiple studies. Unlike other procedures, like surgical procedures, we don't see much effect in incretin hormones, and this makes it exciting because now with newer drugs which acts on incretin pathways, you can combine them with endoscopic treatment to even accelerate weight loss. So with time, there are situations, maybe at around 2 years time, you may encounter suture loosening, suture breaking at the distal body or even in mid-body. In this group of patients, we have identified there are certain cohort who actually benefit from redoing. If your patient was a good responder at the word go, then resuturing is an option where you can give these patients an option to lose the weight that they have gained, and the procedure is not that complex. It's very similar to your primary procedure. The prior sutures, you don't have to remove them. With them in place, you can continue to suture and reinduce the restriction, and even achieve the same amount of weight loss like the primary procedure. With that in mind, and to increase the durability of weight loss, now we have the post-procedure. The post-procedure has a unique way of suturing which is different from your endoscopic sleeve. Here you are going to create multiple plications instead of continuous sutures with ESG. And the way it works is these plications are shown to cause fibrosis and tissue apposition, thereby making these plications stay for a longer duration of time. The first version started with targeting the fundus and antrum of the stomach. Unfortunately, that iteration did not result in significant weight loss. Many reasons were quoted for that, but subsequently the developments in terms of changing the pattern of suturing, targeting the greater curvature of the stomach and impacting on the motility of the stomach led to a modern version of PORS, which is PORS 2.0. So as you can see that this is the suture pattern that was adopted with an idea to shorten and make the stomach narrower. Basically how this plication works is you can see here, this was a procedure we did 6-7 years ago with Gondran, and each plications that we take, as you can see, is 6.6 centimeters long. It actually reduces a bigger proportion, bigger length of your gastric mucosa. So you advance the needle, you release your sutures, your snowshoe sutures, opposes the tissue and maintains the tissue with less tension. As you can see here, a significant proportion of your stomach is reduced. And you continue it to involve the entire length of the stomach. And typically, after procedure, this is how your stomach looks like. There is a considerable reduction in the size of your stomach, as seen in endoscopy and in fluoroscopy. The key here is durability. These sutures are meant to stay here for long. And when we repeated endoscopy at different time points, you can see that the sleeve contour is still maintained, the sutures are all in place, and the distension of the stomach is considerably reduced, even at 1 year time. We extended it to see how these sutures look at 2 years time point. There is some amount of dilation, but you can still see that the tissue position is still there. All the sutures are still intact, and the patient continued to experience restriction because of persistent suture presence there. So when we looked at our own real-world data, at 12 months, we could see that the weight loss was around 18%. The procedure time is shorter. We did have adverse event, but it was one case of perforation, which was closed immediately. The other one was pain, where the patient has to stay in a bit longer. But most of these adverse events did not result in any surgery or anything. A multi-center study which looked at the same outcomes across different centers did show that this weight loss can be maintained as far as 24 months after procedure, and it also resulted in improvement in obesity-related comorbidities. So if we categorize based on the percentage of weight loss, you can see that almost all patients achieved more than 5% weight loss. Close to 80% reached more than 10% weight loss, and in a small cohort, 58%, we could see more than 15% weight loss at 1 year, which is sufficient enough to induce not just achieving weight loss, but also improvement in comorbidities, as you can see here. We see improvement in lipids, we see improvement in ALTs, the fatty liver and CAP scores had a significant improvement at the end of 6 months. So all this weight loss, in fact, translates to hard endpoints. So when we were to compare between different platforms, when we did a match study between ESG and post-2, at about 1 year, the weight loss was similar, and the complication rates were also similar, so there was not much difference. One of the challenges, the number of plications that were placed in post-2. The dual helix pose or pose 2.0 with enfolding technique described by Barham shows that with less applications, you can achieve significant reduction in the gastric volume. And looking at the weight loss, you can see compared to the single helix technique, using a dual helix to reduce the size of the stomach greater, in fact resulted in more weight loss, as much as 20% at 1 year, which is promising. So more data is required to support this, and to also learn how easy it is for many endoscopists to do this procedure. While learning curve is a significant concern with all these endoscopic procedures, the available data says that with ESG you need to do at least 50 procedures to achieve mastery, and these procedures are not widely available, and dedicated training programs to learn bariatric endoscopy is not also widely available. So that poses a significant challenge for most people to learn these techniques. With that in mind, newer innovations are trying to cut this learning curve needs by automating endoscopic suturing, and EndoZip is having this vision to shorten the learning curve and make it easier. Compared to its previous iterations, the latest iteration is very motorized. You just press button, it sutures for you and helps to cinch, compared to its previous version. The first in human study, which I was involved during my fellowship, shows that the earlier generation of device was safe and could induce significant weight loss at 6 months. So these are some of the suture applications that we did after the first generation device. You can see that there is good tissue apposition. The greater curve seems to be collapsed well. So the device works. But one of the challenge with the first generation device is handling it, and automation is supposed to solve those. And with the multi-center study that involved the motorized suturing, you could see that the procedure indeed results in a significant weight loss. At about 12 months, we noticed that the weight loss with EndoZip device was around 14%. So which is again a good head start. So in conclusion, as you can see here, there are a lot of endoscopic tools that are currently available, and all of them are promising in terms of delivering good weight loss. The challenge that we are facing now is accessibility to these treatments and the cost. If those things can be addressed, and if the learning curve can be made shorter, it's a matter of time that we can bring in more people to start doing these procedures and deliver different treatment options for our patient. With that, I thank you again for giving me this opportunity.
Thank you, Ravi. If somebody for the audience has any questions for Ravi. Ravi, I always have this idea that, I know you're not a surgeon, no? Yeah. But we change some of our sutures to barb sutures to hold more the tissues when there will be tension. Do you envision having barbed sutures in any of these platforms? Or the GIs don't think about that?
I think in the initial part when we were discussing about sutures, the question is to make these sutures less inflammatory to the stomach. So that was the original intent when the Prolene sutures were developed. Certainly barbed sutures might seem attractive because they can stay longer, they can keep the stomach configuration restricted for a longer period of time. It's certainly something for us to think about.
Suhendra.
The perforation which you had mentioned, which took place and then was diagnosed and closed. So how was it diagnosed and how was it closed?
So the perforation which we're highlighting was with post-procedure.
Yeah.
Typically, what happens is the G-prox, which has two arms, sometimes when you inadvertently push it, while you're drawing the tissue in, it can penetrate the mucosa and go deeper. Most of the time, it can be recognized because you're going to start seeing fat coming in. So when you start seeing fat coming in, when you're familiar with this technique, you just take another application next to it and close it. Okay. So you don't really have to panic when you see a perforation, because now there are a lot of tools for us to fix this perforation, and these are suturing devices that we are working with. So as long as you recognize it then and there, you can just use the same tool that you're using to close it.
Thank you very much, Pravi.
Thank you.
Our next presentation for Barham Abudaye from the Mayo Clinic, Evolving Endoscopic Metabolic Intervention for Type 2 Diabetes. Thanks, Barham.
Thank you, Natan, and thank you, IFSO, for the invitation. And we're getting to the last stretch, so thank you for those who showed up to this last session. So we're going to talk about the world of using the small bowel as a treatment for type 2 diabetes, exciting new era, and hopefully I will show you the evidence to support what we're trying to do here. But beyond my usual disclosures, my actual disclosure is I do believe that the answer for metabolic disease, especially type 2 diabetes, lies in the gut, not in the bloodstream. And I will show you the evidence to support this notion. But simply stated, before we go to the evidence, right now, if you think about type 2 diabetes like an orchestra that is dysfunctional. So there's miscommunication between the conductor and the downstream orchestra players. Right now, we're just treating the players. So the dysfunction is like insulin resistance and beta cell insufficiency. So now the flute player is the insulin resistance. We go to the flute player saying, you're out of sync. We replace the flute player. Then we go to the violinist and say, your beta cell insufficiency. We replace the violinist. But maybe the problem is with the orchestra conductor it's themselves, and we need to work upstream in order to modify the disease, not just manage the disease. And that's where the gut is truly the orchestra conductor. And this illustrates the complex integrated physiology of the gut in really orchestrating the downstream organs. So the pancreas is not the culprit in type 2 diabetes. The pancreas is the recipient of the dysfunction that happens upstream, same as the skeletal muscle and the liver. And right now we're just focusing on isolated downstream organs rather than upstream physiologic modification of the pathophysiology of the disease. Now, you don't have to believe me for this concept. There's evidence to show strongly this integrative physiology and how could we justify that the small intestines are the orchestra conductor. This is published in the Lancet Diabetes. And the integrative physiology is basically the incretin response. That means when you ingest a load of glucose, your body has to respond to it, and you have to raise your insulin, and that is the sensing function of the gut, raising that insulin. And you could see that incretin effect in the graph in gray here, and in a normal non-diabetic patient, there's a robust incretin response as a function of the gut communicating with the beta cells of the pancreas, with the liver, and with the adipose tissue and the muscle to cause that incretin response. Now, what happens in state of type 2 diabetes? You lose the function of that orchestra conductor, and you diminish the incretin response by about 50%. So you're dealing with a diseased dysfunctional system. You're not dealing with a hormonal insufficiency in that system. So the question is, how do we recapture the integrative function of the gut organizing that metabolic response? And again, there's robust evidence from the literature that's showing that in states of type 2 diabetes, you do not have a deficiency of GLP-1, you do not have a deficiency of GIP. Actually, you have severe resistance to both gut hormones to the level that your body does not respond to GIP anymore. So no matter how much pharmacological GIP you give, there is no response, and you severely diminish the response to GLP-1 in type 2 diabetes. Therefore, the answer is truly in the gut, not in the bloodstream when you're dealing with this disease. And to put the final nail in the coffin on that issue, this randomized trial published in The Lancet that looked at the differential effect of gut-based therapeutics in the form of bariatric surgery that has a small intestinal component versus medical treatment of type 2 diabetes. The medical treatment arm is shown in red, and then the surgical arm, the raw gastric bypass in the blue graph, and pancreaticobiliary diversion in the green graph. And there's a follow-up in this randomized trial to 10 years, and you can see in the medical arm, there's progression of the disease. Patients reach a hemoglobin A1C of 7 on multiple drugs, but then they lose their response over the long term, and they require progression to insulin. In both surgical arms, the raw gastric bypass and the pancreaticobiliary diversion that have small intestinal component, you could see maintenance of optimal glycemic control over the long term at 7 years. Now, the best measure for progression of type 2 diabetes is the need of insulin. In the medical arm, 50% of the cohort progressed to require insulin in the 10-year horizon. In the OI gastric bypass, only 5% progressed to require insulin despite weight regain at that time horizon, and 0% in the pancreaticobiliary diversion required conversion or required insulin at the 10-year horizon. Now, it's not all rosy for bariatric surgery because although it is the most effective in managing and modifying the disease of type 2 diabetes, you could see this is published in the JAMA recently. This is all the bariatric surgery trials that compare bariatric surgery versus medical therapy for type 2 diabetes. And the story is still very nice in the first 5 years. You could see the dots in blue is the remission rate after bariatric surgery versus the dot in orange is the remission rate after medical therapy. And you could see that bariatric surgery is definitely dominant. But what you could see over the 5-year horizon, there is erosion of that response. And you could see that although even at 12 years, the surgical arms are better than the medical arm, there's significant reduction in that response. That means it's not permanent, and you're going to need to convert and reverse in order to manage the disease. And that's where the anatomy preserving or the organ preserving nature of endoscopy will play a role in using the same pathways as bariatric surgery in order to reset the metabolic clock as an upstream treatment goal. And nobody has better access to the small intestines other than with a simple upper endoscopy. And with simple upper endoscopy, if you magnify it, you will see that it looks like a tongue, right? Because that's the sensing gut. It senses what's going on in the lumen, whether it's from the nutrient that we eat, the microbiome that we live with, the gut immune system, and it communicates that signal to the downstream effects in order to orchestrate the metabolic response. So each one of these crypts and villus is like a chemical factory of active metabolic substances that manages diabetes. And again, if we put the duodenum as the center of the orchestra conduction, it has to integrate signal from the food. It has to integrate signals from the microbiome and its metabolites. It has to integrate signal from the gut immunity, which is very robust. Otherwise, we would be rejecting ourselves with everything that we eat. And it produces active substances like GIP and GLP-1 and PYY and others in order to communicate these integrative signals, not through the bloodstream, through the submucosal enteric nervous system, because these are immediate refluxes. And if you could see, if you go beyond the mucosa here to the submucosa, there is a robust enteric nervous system that communicate these signals through the vagal afferents into the end organs of the pancreas, liver, muscle, and others in order to orchestrate that response, as shown in this cartoon as shown here. Now remember, I showed you this cartoon. It looks like the coral reef and like the tongue. This is the actual image of that duodenum. You put it underwater immersion. You use the magnification function on the modern scope with narrowband imaging in the duodenum, and you could see these nice crypts and villus that are homogeneous. They're sensing what's going on in the gut as far as ingested nutrients, and they're responding metabolically in order to respond to that. Now, integrate that we could integrate that duodenum and biopsy it. And if we biopsy the duodenum, and this is on a protocol to do spatial trapscoptomics, but you could also expose the submucosa. And here we're putting some water to expose the submucosa. And you could see once you expose the submucosa, you have a submucosal plane that you're looking at the submucosal plane here, and you can see the muscle fiber in the background. If you put confocal microscopy, that's what you would see. You would see a system that looks like the central nervous system. These are the submucosal enteric nervous system. It has many neurons, and it is responsible to orchestrate that metabolic response. Therefore, mucosal and submucosal regeneration is an important concept in this field. And in state of type 2 diabetes, this signals becomes dysfunctional. So you have inertia in that communication. And the question is, how do we regenerate this in order to recapture the metabolic response using the gut as a disease target? Now, what happens to the proximal intestines in states of type 2 diabetes? Multiple good basic science and translational science paper published in this end, you could see that with a Western-style diet in a genetically susceptible cohort, you would have overwhelming of the machinery of the duodenum. So you have a state of low-grade inflammation. You have dysbiosis. You have impaired barrier function of the intestines, increased pathogen translocation. And what you would see is two things. You would see that the inflammation in the submucosa causes gliosis and fibrosis of these nerves. So that's why you lose part of the incretin response. And number two, the junction in the small intestines become leaky, so you're dumping this inflammation to the portal circulation, and the inflammation in the duodenum ends up being inflammation in the pancreas, inflammation in the liver, and that could be the upstream effect of the disease. So that inflammation that you're seeing in the duodenum is communicating to key metabolic organs. And the question is, could we use endoscopy in order to have a therapy that's organ sparing, safe and effective, with no long-term consequences to health, and minimally disruptive to the patient lifestyle to manage and treat and modify type 2 diabetes. We heard about the gastric procedures and how they work. Their effect is mostly mediated by weight loss. So if there's no weight loss with the gastric procedure, there's no improvement in diabetes. So they work by reducing adipose tissue, and the weight loss results in improvement in insulin resistance. Now, the interesting part in modifying type 2 diabetes and modifying the inflammation comes from the small intestinal procedures, because they have weight loss independent effect by working on bile and fat acid signaling, insulin resistance, improvement in beta cell function, incretin and microbiome, and most importantly, inflammation. So my task here is to talk about the regenerative procedure that's able to reverse the clock and improve the duodenum integrative function in managing type 2 diabetes as a treatment for the disease. So the first procedure we're going to be talking about is this reset procedure, which is recellularization induced by pulse electrical field. The novel part of this procedure is we're not used to anything non-thermal in the GI tract, but this is truly a non-thermal procedure. That means there's no heat being generated. This is a flexible circuit that is able to emit pulse electrical fields, so high voltage electrical fields, but only for a nanosecond. So any cell with a phospholipid membrane goes to programmed cell death and regeneration, but without affecting the extracellular matrix and without affecting the lymphatics and the blood vessels. So you're able to regenerate mucosal and submucosal living cells without affecting the structure of that duodenum, so the risk of complication and collateral damage is minimal. So let's see how it looks. This is the duodenum before the treatment. If you magnify and use narrowband imaging, you could see these diabetic duodenopathy changes that I showed you earlier, where the duodenum cryptand villus becomes irregular and they become diseased. And here is you're applying the pulse electrical field. You could see a homogeneous blanching from the pulse electrical field that you're seeing without a coagulative necrosis. If you look in an hour, you could see that it turned from white to back to pink, because there is no thermal energy there. But if you magnify with narrowband imaging, you could see this is the untreated duodenum, this is the treated segment, and you could see as if you removed an old carpet, you expose the floor, which is the submucosa under it, and now both the carpet and the floor are being regenerated, and you have a new carpet in that duodenum as shown at 4 weeks later with complete gross healing of the structure. So really quite safe interventions. So now it's been in multiple countries, Netherlands, United States, and Australia, actually. It all started in Australia, so thank you, Australia, for pushing this forward. And the early work was focused on finding the optimal dose, so it's dose titration. So you have 3 groups, low, mid, and high electrical dose. And when you see such a robust dose response, you know that you're having a true therapeutic effect. You could see we have little improvement with low dose, moderate improvement with mid dose, and the high dose, you're reaching 1.6 A1C improvement at 1 year in a cohort that has had diabetes for 5 years on at least 2 medical therapies for the disease. So you're having significant disease modification and regain of the glycemic response on this procedure. Now, the other technology that also uses the duodenum, it does not go as deep because it's thermal-based, is hydrothermal ablation from a company called Fractal. So this is they induce a submucosal lift, and then they introduce heated water in order to ablate the mucosa without affecting the submucosa. And again, targeting the duodenum resulted in improvement in hemoglobin A1C at 12 months, as shown in this high-quality publication in the gut. So in conclusion, therapies targeting the gut for correcting metabolic maladaptation in type 2 diabetes represent a new frontier in type 2 diabetes management. They have the potential for disease modification and decreasing the burden of disease with progression to insulin. So they're going to be an important value added, because we're going to embark on an era where your local primary care physician who's having a hard time keeping their patient under control with easy drug therapy for the disease could send the patient to their local surgeon or local gastroenterologist for a outpatient safe procedure that prevent them from putting the patient on a more complex regimen of insulin and keeping the patient under control. And if you have to repeat it every 2 years, still a significant value proposition because of the authorizable nature of the technology. So the future is exciting, and thank you for your kind attention.
Thank you for an amazing lecture, but thank you to remind me how ignorant I am. So whoever wants to make a question, Christine first.
Thank you, Param. Extremely impressive. And I love the way that you described the orchestral conduction of the metabolic answer. And I have a very pragmatic question. After all we've heard from you, would you say that this is the answer why diabetic patients do not respond in the same way to surgery as well as to the medication with weight loss?
Absolutely. So just a little bit of history of these medications. The first molecular first drug target for incretin treatment was not GLP-1, was GIP. Because GIP is produced in the proximal gut, and it's 10 times more potent incretin than GLP-1, which is a distal gut incretin. But when the pharma companies started the development process of using GIP as the incretin of choice, they realized that despite the dose that they would use, the body in diabetics are just resistant to GIP as drug. When they tested GLP, the body was still 80% resistant to GLP, but if you overwhelm it with the very high doses of GLP, you get a response. That's why GLP became a target for type 2 diabetes treatment. So absolutely, it's pretty clear that the body is not deficient, it's resistant to both hormones. But you overwhelm that resistance by giving super physiological doses that lingers in the bloodstream for a long period of time. Therefore, the hope is to kind of reset the resistance rather than keeping adding the hormone that is not deficient in this disease state.
Abraham, I have another question. We know from surgical literature the amount of small bowel that we bypass during RYGB is longer. And compared to all the ablation techniques that has been developed, it focuses on a short segment of the proximal small bowel. How do we determine what length of small bowel ablation is needed in order for us to achieve good diabetic control or even improve, regeneration of all these good villi?
Yeah. So there's a lot of unanswered questions, even about the physiology of bypass procedure. And so there's a lot that we don't know. But we know that bypassing that organ gives it time to heal because you remove the insult, which is different than regenerating it. So that means if you're regenerating the signal, you might not need to use long segments because that's different than the bypass phenomena. They both have some common denominator of how they work, but there's still unanswered questions there. But in physiologically speaking, your body, your food does not need to wait until it makes it to the jejunum for your body to produce the incretin response. Otherwise, you would die from hyperglycemia. So the signaling for orchestrating that response is very proximal within that duodenum, and you would lose most of it actually in the jejunum. So it's likely the duodenum is the right physiological target that makes anatomic sense because you have to respond to it as it enters the duodenum rather than distal into the small intestines.
Question?
I just want to say, I've always told my patients that there's some magic in the C-loop of the duodenum, and that taking the enteric stream away from that C loop is there's magic. So I just wanted to thank you for telling me the magic. It's pretty good to be able to come to a meeting and have sort of a paradigm shift in the way that you're thinking about this stuff. So that's great. What do you think about in the future having sleeve plus doing this every couple years as a tandem deal?
Yeah, and that's the beautiful future that we're excited to. Sleeve gastrectomy is a very effective surgery. But if you look at sleeve gastrectomy and you look at those who had weight recurrence, you would see that you would lose all the anti-diabetic effect. So, and we did this study at the Mayo Clinic where we took everybody who got bariatric surgery and had diabetes before the bariatric surgery. We selected the cohort that reached remission after bariatric surgery and had follow-up for 10 years. And then at 10 years, we divided them into quartile of weight regain. So we took those at 10 years who regained all the weight back. So you can see with the sleeve patient, they got remission, they gained the weight back, their diabetes came back completely. With the OY gastric bypass, they gained all the weight back. Only 60% of them had remission of type 2 diabetes at 10 years. So there's some magic there, and I think it's not magic anymore. We're starting to understand more what's going in there. So that would be the deal. You do sleeve is a great procedure, produces robust weight loss, enough to put the disease under remission, but diabetes might come back with the weight recurrence, and that's when you could add this as a salvage without needing to convert to more aggressive procedures.
The last question, Bara. Will be any contraindication to combine medication, this procedure, another endoscopic procedure, or another surgery?
No, and that's the beauty. So now if we're hypothesizing, and again, I emphasize hypothesizing, if you're hypothesizing that we could decrease the resistance to the hormones, to gut hormones, like GLP-1, we might be able to add the cheap generic GLP-1s, like liraglutide, plus this procedure at a lower dose. And that is where the interesting future lies in advancement in both fields.
Thank you very much.
Yeah.
It's my pleasure and honor to introduce the next speaker, Professor Nathan, who will be sharing on hybrid endoscopic and laparoscopic interventions, spare the anatomy and maximize outcome. Over to you.
So I love all these things that we're doing. I really love them, but I think for a time, the bridge between surgery and endoscopy will be hybrid procedures. And I am a true believer in that one, not only because it will help us close that bridge, but also because it makes it safer by the time we can do it only by endoscopy or by percutaneously. So this is my disclosures. So I'm thinking a lot about this, why hybrid approach is needed for bariatric and metabolic surgery. And I came to this, my conclusion, probably there are more. But when notes came to the endoscopic and surgical world, we were not ready. It's not that the concept was bad, we were not ready. And I think this hybrid procedure will help us because we are not fully ready to do it only by endoscopy or percutaneously. For example, the first time I got offered the magnets, they wanted everything by endoscopy, but they told me through colonoscopy they can only reach 80 centimeters above the ileocecal valve. So I don't like nobody to tell me where I should put my anastomosis. And that was a limitation, so I didn't accept to work with them or help with them until they decided to go hybrid, because we were not ready to do what we think is correct. We are not going to do something because just we can do it. So we were not ready to reach some specific places without going to surgery. I think we are getting there, but we still not have the full technology to safely deliver all the devices. And to help close this bridge, I think we need to do this hybrid, and that's what I'm going to talk. We surgeons have the same surgery, so I've been doing this for a long time. But if we find a safer way, because I think for some time, we're still going to be doing surgery. So the new surgeries that we're doing, we need to find a safer way to do it. And I think the safer way to do it will be also through surgery. But the most important thing is this one, safety. No false safety, safety. So we need to make sure that by the time we're able to do everything by endoscopy, we really know where we're gonna be doing it. And that's what we're gonna make some examples. But also to understand that when you look in the US, the numbers who are been growing are the revisions. So we need to find a better way to do revisions. Surgeons have the tendency to think that we correct, repair everything with another surgery. But nobody sent us to the world with zippers. So I think we need to find a better way to do this for our patients. So that's what I think that endoscopy and medications will be the end of, the final end. So we know about the ESG, we heard about it, we know about other sutures. But what I like about it is that even after you do it, you have the chance to combine or to add another procedure. And this is something that surgeons ask all the time. What we did before shouldn't prevent me to do something else in a chronic disease, as Christine mentioned it. So one of the things we did is we needed to prove that after ESG, we can convert them either to sleeve to a bypass. So we published this already twice, and now it's going to be in the SAGES manual. And you see the image of a ESG through laparoscopy. So when they say it looks like an accordion, it looks like an accordion. And second, this is the image of the endoscopy at the same time. And when they tell you also that the sutures can get loose, that is true too. So it will be a physician decision, surgeon, GI, or the group that I think is the one who do better decision is the multidisciplinary group, to decide if you suture again, discuss it with the patient, or you go to a sleeve. The only difference when I convert those patients to a sleeve, I don't use a bougie because I want to see the anchors. I did the stupidity to try to remove the anchors before surgery twice. It's worthless. Not only is it very difficult to find them all, it bleeds if necessary. Why remove them? Because you can staple through the anchors, but you cannot cut. So you staple beautiful, then you cut, and then you're going to have holes and going to get leaks. So what we do differently, and thank God most of the ESG, they are wider than my sleeves. So I just need to go medial. But what I use, not a bougie, I use my scope. So with the scope, I make sure that wherever I'm going to staple, there is no sutures and there is no anchors. So that's the only thing I change. Of course, making sure you don't destroy the scope because they don't come cheap. But there are other things that is going to help you. So every time you discuss with surgeons, some people who love minimal invasive things, and you say, we still need to open holes when we do hybrid. Then we are working with a couple of companies to do that much easier. So you're going to see this is a device by a company called Sager that has a stapler, but also come two hooks that will allow you to close that gap. You put the hooks on every side. We don't need to put stitches anymore there. And you stretch it. When you stretch it, the device allows you to twist that one and bring it to your stapler again. As you can see here. And then when you twist it, you're only having that gap that you want to close with another stapler. That make our anastomosis quicker, our closing of the gap quicker and safer. And we've been trying this already in some trials for colorectal surgery at the beginning, and the plan is to move to another ones. But that will help us close those gaps that you're gonna see we're gonna do. I want to thank Omar. Omar sent me this because I don't have no experience with this one, but I love what they're doing with this. And Barham, of course, less invasive anastomosis by endoscopy. And I have some questions in my mind that I'm going to mention for sure. This is a project, it's called SAGES, Single Anastomosis Gastrointestinal Endoscopic Bypass System. The plan is to do everything of this by endoscopy. So as you can see here, the plan is never need to go to surgery. You're going to have anchoring systems that will accommodate to the movement and motility of the GI tracts, prevent migration, and not only prevent it, but also prevent it in a safer way with no anchors, with no metallic sharp things that can cause ulcers and problems, but in this way. And then, through, of course, manipulation by endoscopy, you will be able to create an endoscopic full internal bypass. And it will move, and it will change while it's neutral, what there is contraction, and it will come back to the position. I know this is a dream, but it's a dream that is becoming reality, so we're very happy to see it. When surgeons see this, they have a seizure. I don't know if because it's removing surgery, but I think it's not perfect, but it's coming well. So there is a quick video to understand, because for the one who doesn't do endoscopy, this is how it plays. And in my mind, and probably Barham will tell me later, yes, you have to be a skillful endoscopist, but this is not as crazy, that difficult to do. If you have proper, maybe ultrasound, fluoroscopy, whatever they're using to do this. And whoever uses already guide wires will be able to do this without a problem. In my mind, I will do the first cases hybrid with laparoscopy, making sure we're grabbing the proper part of the intestine, we don't have any problems with the opening or putting the stents again. And once we are happy with that, with a certain number, and see that the results are valid, then we can move to a full endoscopy one. I'm not trying to prevent it, on the contrary. I think we need to do it safer so a lot of people can do it and feel relaxed when they're doing it. It will need, of course, precision in places. It will need some dilation to create the openings. And that opening is the one we need to make sure that it doesn't leak, it doesn't fail. But the type of stents that is going to be placed there, it reminds me my old grandma, where he has all the things to sew, is the same, and you're going to see here. The deployment of the fixation stent that is going to be mobile, that I think that's one of the most interesting things that I've seen here. And then as you see, you dilate, you're going to bring the distal part of the tube. And then you just separate it to the whole device. And then you put whatever you want to call it, that type of stent that it will protect for the future. So you can see some of the endoscopy here. I put you the video because for people who doesn't do a lot of endoscopy, it can be confusing. But look at how this anastomosis look. It looks probably same or better than my anastomosis. So I think if we can save this approach, if we can check for a while by hybrid views, then we'll be happy doing this. And probably this bypass have less implication for the patient. You see some of the results. You can check with fluoroscopy, endoscopy, and the deployment of all this. And you see the final version. X-rays, when it shows you that you can really do a true bypass without doing any other stuff. And this is some of the weight change that they have in simulated controls. And we're going to wait to see the results. Barham, Omar, we hope this goes very well, because I think this is going to change a little bit what we do. But also, if we're going to do anastomosis, we need to do it safer. I mentioned to you about the magnets. Now that we're doing hybrid, I'm happy. The concept of the magnets is that the magnets are going to couple. And then the tissue will be remodeling and necrose, and then you have anastomosis. It was presented to me the first time that I didn't like, and again I mention it because I didn't want them to tell me where I put my anastomosis. But the results are pretty good. If you can see here, when we do this, day 4, now when you do stomach and colon, it can take up to 7-8 days, but this one at 4 days, it creates an anastomosis. And when you check them, 1 year later, 2 years later, still there. So far, there's been no leaks and no bleeding. And the dream of any surgeon is have no leaks and no bleeding in any anastomosis. There are issues, of course. There are some of these anastomosis, for example, for a gastric bypass, is too big. But for SATIS, for a colorectal anastomosis, even for OAGBs, it's perfect anastomosis. So let me show you how we decided to go hybrid at the beginning. We do a small opening by laparoscopy. The companies designed a laparoscopic device to put the magnet. This is octagonal magnets, 8 millimeters. Once you place them, you need to close the enterotomy. And I still was not totally happy, but at least being happy, because when you open a hole and you close it, something happened there, for sure. So we need to do this safer, but they'll allow us, to be honest, to start to doing more things. And as you're going to see here, so I can advance it a little bit, the deployment, because you have the endoscopic view, the fluoroscopic view, and then we go back. We move to something even further. That's what I want to show you. Now, because when you do a terminal anastomosis, you cannot wait the 4 to 8 days and this open. When you do a terminolateral anastomosis, you cannot wait for the 8 days to open. So we need to find a way to make sure that if we don't do lateral, any other one has to be open since the beginning. And that's what we came up. So we create the same opening, but we're going to deliver before the magnet this, and this is a true case. This is patient that we already did in Chile. So you leave this opening here, and this is going to be the part who's going to protect this opening. So when you see, the next step will be to deploy the magnet around silicone device. As you see here again, this is doing a SATIS procedure. And then you do the same in the other side. You do the same now in the other side of the intestine. And then they have some string, you just pull them together. And then you already have the hole inside. So terminolateral is not an issue anymore, as you can see here. The good thing about laparoscopy today, I make sure there is no kinking. I make sure there is no tissue inside the magnets. And now this is thing that we're going to need to solve in the future, probably. But so far, we are waiting for better anastomosis. The other good thing is you can check it by endoscopy. At the same time, you're watching by laparoscopy and doing blue methylene if you want. You are checking that the magnets are coupled well, that there is no kinking. More than that, we started to do studies with ICG and see how it looks at this moment and see how it goes. After a time, when all the necrosis happen, everything is going to go away. There has not been one reported incident of not being able to expel this. We didn't ask anybody to look for it because that would be a little bit disgusting. But there have not been issues with you expel them that. This is our OAGB, exactly with the same concept. And how it looks up there. You can do it for any anastomosis. The biggest studies now that we're going to run will be in colorectal. Imagine you have a colostomy, for example. You just put a magnet outside, bring back the colon inside the abdomen. You go by laparoscopy, you connect other magnet, and see you later, alligator. Things like that are going to change what we do. This is very interesting. This is a patient that we did the procedure with magnets 1 year ago. It came with cholelithiasis, so we need to go back and remove the gallbladder. And we went, of course, with surgeons, with curious people, we went to see how the anastomosis looked 1 year later. Look at this. much less inflammation, less additions that we had with our own laparoscopies. This is 1 year after for anastomosis with the magnet. So it looks beautiful. That was a coincidence. But I have a proposal that I did to them. I think if you are doing terminal, lateral, you should use what I show you. But if you're doing lateral, I don't want to open holes. So we are playing now with a device that if you deliver the magnets to me, I will be able, with an instrument, to position wherever I want without holes. And then they put the second one, and then we just couple them. And no holes, still hybrid, and still gonna look. We are not there, but we're gonna get there. Lastly, I'm totally a believer that endorobotics will be much better, even than the robots we use for laparoscopy. So the future, we had the wrong concept that we can do stage intervention. I think the future is combined therapies, either simultaneously or one after the other, as Christine mentioned. The most important concept for me when you try something new is primum non nocere, from Latin, that I translate, kill as few patients as possible. And then, less aggressive approach, AMI, or endoscopic, or hybrid, for revision, and endorobotic is gonna come to help. We do this gap more safely if we do it hybrid. Thank you very much.
Thank you very much for the exciting talk. We open the floor for questions.
I think we all want to go home. So I want to thank you, Ravi. I want to thank you for the patient to be in the last session of a long last trip and a long last meeting. I think it was a very productive meeting. Thanks, Australia and IFSO. So I wish you a safe travel back home if you are not at home. If you are at home, enjoy the city that is marvelous. Thank you very much.